Acute liver failure, as colleagues will be aware, is caused by a variety of etiologies, but particularly pertinent is our role in promoting good health standards in terms of fecal-oral transmission, particularly for hepatitis and hepatitis E, ensuring that our patients are appropriately vaccinated, particularly for hepatitis B, being cognizant in terms of drug therapies that we may prescribe or patients may take from herbal remedies, that these can be hepatotoxic. When someone presents with an illness that might pertain to liver disease, then we need to do the appropriate tests and withdraw any potential putative toxins, such as drugs, that might be potentiating the disease process. Early recognition really is having an open mind as a doctor and considering, is this an acute liver injury? Obviously looking at routine blood tests that one might do, and the finding of a transaminitis or early hyperbilirubinemia should consider the cause as being an acute liver injury. One then again needs to look at the possible causes and make sure that you do the appropriate investigations pertaining to that. You need to be very conscientious in tracking blood tests, and if they are deteriorating, ensuring that you're doing axial imaging, ultrasound imaging, and consider, importantly, ongoing referral to a specialist centre who has great experience in this field. What one needs to do is to recognise that you go from acute liver injury to acute liver failure. That is really by virtue of developing coagulopathy. So you measure the INR, you see elevation of that, that suggests that you have a major liver injury. That is usually seen with a rising bilirubin and either a rising or a falling AST, depending where the patient is on their clinical course. What is really important then is to start thinking about, will this patient develop complications or will this be a self-limiting illness? Procrastination is very detrimental to patient care. It is unacceptable in this day and age that patients deteriorate to develop encephalopathy, high-level encephalopathy, in a hospital which doesn't have the expertise to offer critical care support and potentially transplantation for those patients who develop complications. So if you have any patient with acute liver injury who develops abnormal neurological function, you should be thinking about referring them. The importance, particularly for acute liver failure and acute neurological failure, is early intervention and care of the airway. And that is very pertinent in India, where transfer distances between hospitals might well be considerable. So you need to speak to your tertiary centre early, you need to get advice as to how to optimally transfer these patients. To try and mitigate against complications, one should maintain the sodium in the normal range, and that means avoiding large volumes of 5% or 10% dextrose. If you need dextrose to maintain blood glucose, please use 20 or higher concentrations. Do not dilute the patient with the risk of hyponatremia and cerebral complications. Be very aware of renal function, looking at hourly urine output and also changes in creatinine. All of this is suggestive of kidney function, which again should be treated early with continuous therapies of continuous renal replacement therapy as opposed to intermittent dialysis, which is detrimental in the context of liver failure. In terms of coagulopathy, interestingly, these patients are not at risk of bleeding. They have balanced coagulation disturbances, and so although you see a high INR, providing the APTT is reasonably maintained and the fibrinogen is not significantly depleted, you should not bleed, and therefore use of fresh frozen plasma need not be considered. I cannot emphasize enough the importance of, when you start developing even minor suggestions of complications, you must refer these patients up through the system to the tertiary centres who have real expertise in managing these patients, where we see the outcome from acute liver failure without transplantation actually improving significantly. A small percentage will require liver transplantation. They also need to be referred early to optimise their chances of surviving this operation and finding either a suitable donor, be that cadaveric or living related.